As you can see, we are in Washington, D.C. This is TCT 2016, and we're taking this opportunity to talk to a variety of authors for papers in JACC, and in this case, JACC Interventions. It is a systematic review of TAVR for pure native aortic valve regurgitation. And to do this, I'm with Dr. Thomas Pilgrim. Thank you for coming back, by the way, from Bern University Hospital in Switzerland. It is always great to talk to you. And this systematic review, how did it get started? I mean, what was your interest in doing this paper?
Exactly. So we know that transcatheter aortic valve replacement is very successful for the treatment of patients with severe aortic stenosis. And the spectrum of patients is also expanding. So, I mean, we are expanding towards low-risk patients, but also towards patients with off-label indications for TAVR. For example, patients with bicuspid aortic valves. We perform valve-in-valve cases, and I think a third subset of patients with off-label indications but still get TAVI is patients with pure native aortic valve regurgitation. So we were interested to study this.
So who were the patients that you were reviewing in this systematic review?
Yeah, so in total we included 13 reports with, I think, including 237 patients. All of them were observational studies, short-term outcome. We have to acknowledge that the reports were very heterogeneous in terms of patients' characteristics, access route, devices used. So that's what he did. The primary outcome of interest was all-cause mortality at 30 days, so we didn't have any longer-term outcome. And what we found actually was that approximately 80% of patients have been treated with self-expandable devices, whereas 20% of patients were treated with balloon-expandable devices. A device success range between 74 to 100% in the different reports. And in the end, all-cause mortality amounted to 7%, which is still considerably higher as compared to 30-day mortality rates among patients treated for aortic stenosis. Also importantly, 7% of patients needed to have the implantation of a second valve. 2.5% of the patients underwent conversion to surgery, which are high numbers. And the rate of moderate or severe AR was still 9% after implantation of the valve.
So are we safe to assume that these patients, this is what they really required? This was after thoughtful, they really didn't have any other options, so they decided that this was the route to go?
Yeah, I think all of those patients were reported to be inoperable. I mean, since this was a systematic review, we couldn't check, right?
Yeah,
but
exactly.
It was reported that all of them were inoperable.
But you can probably assume maybe that...
Yeah, I mean, I think this is really necessary since surgical aortic valve replacement has very good results for this indication. And I think unless the patient is really inoperable, we don't, at this stage, we don't have any reason to do TAVR.
So were you happy with the results? I mean, does it look like this is, if you're forced to go in this direction, that at least the results are...
Well, happy. I mean, as I mentioned before, event rates are considerably higher as compared to patients treated for aortic stenosis. Right. I think there is lots of potential to improve outcomes, maybe with second-generation TAVR devices that might have better outcome due to the potential of repositionability, due to skirts maybe, that may decrease the amount of aortic regurgitation.
But somebody has to collect the data before we can figure out.
Exactly. Also at this stage we don't have any dedicated devices. There's also only one device, the JACC valve, that actually has a CE approval for treatment of aortic regurgitation. Yeah.
So at this point in time, what are the conclusions that you can take away from this systematic review?
Yeah, I think we have to be very cautious to get any or to draw any firm conclusions because there are several limitations to our analysis. As I mentioned, number of patients is very modest. We don't have any long-term follow-up. Patient characteristics were very heterogeneous, different devices, different access routes. So I think we have to be very cautious. But still, I think what we have shown is that there is feasibility for this technique, also for patients with pure AR. But we need to wait for novel devices, dedicated devices maybe, that may improve the outcome of those patients.
So the next step is really to hope for new technology before you go any further.
Yeah, that's what I think, exactly.
What's on the horizon, do you know?
Well, no, I actually don't know. I mean, there are several repositional devices that that haven't been studied, for example, such as the Lotus device that is completely repositionable, but there are not a large series with this valve for this indication. There are also some other devices that may have a potential to improve outcomes.
Well, there's just not a whole lot of information available, so that's why it's rather important that you take a look at this JACC Interventions. It's online before print, and it's a systematic review of TAVR for pure native aortic valve regurgitation, and it's Pilgrim et al. And for CardioSource World News and CardioSource World News Interventions, I'm Executive Editor Rick McGuire.